We're going to go on the area that's on the screen. Here, this doesn't time out. So glute max, what's its primary action? Hip extension. So we're going to flex the knee. We're going to put her slightly in the hip extension. She's going to hold her leg up in the air like so. I'm going to let go. Can you hold your leg up?
Oh, hold it.
Yes. All right, there we go. One hand here for support, the other one here, and resist as I try and take her out of extension. And relax. Any pain?
No.
No? Okay. And then we compare to the other side. All right. How long are we holding these resisted muscle tests again? Anywhere from 6 to 8 or 8 to 10. So about 8 seconds. All right. Why? This is kind of preempting next week's test. Why do we hold the muscle test for 8 seconds? Why don't I just say, hold your leg up? Okay, you're good.
Because it lets you know if there's some weakness within the muscle, because it's unable to sustain that contraction.
Yeah, remember we're looking for two things. Can the muscle initiate the contraction, which essentially tells us about how well the information goes from here to here, okay? And then sustaining the contraction tells us about the health or the integrity of the muscle tissue. All right. Piriformis does external rotation. So we're going to put her into external rotation, which again is the foot goes this way, the femur goes externally. Okay. We're going to have you hold your leg there, and don't let me pull you back towards the midline. And relax. Any pain with that? Nope. Okay. So it'd be piriformis or really anything that does external rotation. We don't usually test the strength of the internal rotators per se, because we end up testing those muscles by their other actions. So glute medius and minimus, let's have you turn so you're lying on your right side facing towards the board. We're going to test the medius and minimus by engaging their action, their primary action, which is abduction, right? So we're going to see, can they shorten this way and hold the leg up. So we're going to keep the bottom knee and hip flexed a bit. We're going to straighten this leg out. I want to stabilize at the iliac crest so that as I bring this leg back in line with her torso, that she doesn't roll backwards. Okay, so I'm going to stabilize here, bring the leg back in line with the torso. We're going to slightly abduct because that's primarily what they do. We're also going to do a little external rotation. That's going to help isolate the glutes a little bit away from the TFL. You're going to have to hold your leg there and resist. And relax. Okay? Any pain with that?
No.
Nope.
Just trying to flex.
Trying to hold it on. Yeah. Right. Okay. So again, leg back in line with the torso. Make sure there's no rotation happening in the body. Abduction and a little bit of external rotation. So let's see that one again. So here, line it up, abduct, externally rotate. Again, the external rotation helps us take a little bit of TFL out of the picture, and then pushing down. Okay.
Definitely tighter to turn it out like that.
Tighter to turn it out. So as we externally rotate again, we're getting tension on the fibers that do internal rotation, which mirrors what we did when we were assessing passively. Okay, so if anything, she might have some tension in the anterior fibers of glute medius and minimus and TFL that came up on not only passive range of motion but also the resisted muscle test. Okay. All right. Adductors, just for time's sake, I'm just going to do adductors on the other leg. So we're going to bring this one back, straighten it out, that one forward. If the pelvis really rotates here, you might want to have a bolster or a pillow under the knees. Okay, she looks fairly neutral here. Okay, but to test the adductors, really simple. Put them slightly into adduction, hold your leg there, and resist. And relax. What if somebody had medial knee issues? Yeah, if I'm pushing down here, that might be putting a lot of stress along the medial aspect of the knee. So we just shorten it up. So hold your leg there, bring that hand just proximal to the knee joint. Okay.
So with that, if that were the case, then would you want to adjust at all how you had your hand positioned so you're not so much on the attachments of it? I mean, I'm trying to figure out how would you do it where you're not.
It's pretty
creating some sort of
challenging to
inversion.
not put them right on the adductor. So as long as your pressure is fairly broad, you should be all right. Okay. All right, let's have you face up. Iliopsoas and TFL. These two can be a little challenging, okay, because they share two movements that we're going to put the hip into. In both cases, we're going to do flexion and abduction. Okay. For the TFL, let's stick to yours. So the psoas, we're going to stick with the fact that it also does some external rotation. Okay. So again, we're going to flex, abduct, externally rotate. She's going to hold her leg like that. I'm going to stabilize on the opposite ASIS. Have you hold your leg there and resist as I push down and out. And relax. Any pain?
No, but it was hard to do.
It's hard to do.
Yeah.
Yeah.
Weakness, a little waiver.
Yeah, a little bit of shaking there. TFL is going to look similar. We're going to flex, we're going to abduct, we're going to internally rotate. Remember, those are the three actions that TFL does. Okay, so hold your leg there. Same thing, I'm going to stabilize here. This time my pressure is going to be down and in. Keep pushing out, up and out, up and out.
Yeah, this one's hard.
Yeah. And relax.
Oh,
Was that the hip or is that the knee?
It's a hip.
Okay. So, a little weakness on TFL, a little click. So TFL, it was interesting because she said it clicked here. I heard some of it, what sounded like it was down here. But again, TFL has come up in a couple different formats, right? It's not elongating, it's a little weak. So it might be a little stretched out. And the anterior fibers of glute medius and minimus are really what are driving your internal ability to internally rotate. Let's just explore that TFL and see. It's tender at all.
There.
A little bit there. So that would be an
Yeah,
area,
that's
yeah,
it.
that I would explore. I mean, so far, in terms of the clicking in the hip, we haven't come up with a lot, but maybe TFL. And it's definitely tight and tender in here. Okay. Rectus femoris, this one's pretty easy. It flexes the hip. Hold your leg like that. I'm not going to go right on the proximal attachment, but nearby for stabilization and resist. Just pushing straight down into extension. And relax. Okay, any pain?
No, it's just hard to do.
Yeah. Okay.
It does feel weak.
Okay. And then sartorius, we did a little bit last time for pezanserine tendonitis. We're going to put the leg slightly into its actions. I'm going to pull at the ankle and push on the top of the femur, trying to straighten her leg back out towards the table. And relax. That would look pretty good. Okay. So nothing huge of note, but a little TFL would be where I would land. So still kind of stomach gallbladder again? Really? I don't know. I mean, it's somewhere along that pathway, right? Kind of halfway between. I don't know. Anything come to mind on your end? TFL?
Yeah. TFL, if there is the iliopsoas weakness too, in the sartorius, then it's almost
31.
Chongmai,
Oh.
along with belt combination, which is overlap of stomach and gallbladder.
All right. Questions, thoughts?